Hello, students. Welcome to Gastrointestinal Pathology, Part 2. So today, this section, we're going to talk about the small intestine. I think we're going to end just before the large colon, and that will be Part 3. So the small intestine, anatomy and physiology, I think I covered this earlier in the first podcast, but in humans 5 years old, it is approximately 7 meters long. Has a diameter of about 1.5 inches, and it's comprised of three parts: the duodenum, the jejunum, and the ileum. And in the small intestine, final stages of digestion actually occur here. Here, partially digested food particles like proteins, polysaccharides, and fat globules are converted by pancreatic and bile enzymes into basic components of amino acids, monosaccharides, and fatty acids. Here, they will cross over the GI epithelial cell wall into the blood or into the lymph. Most nutrient and drug absorption is in the small intestine. And then there's the gallbladder, which obviously stores bile, and the presence of fat in the small intestine, or the duodenum specifically, stimulates the release of bile from the gallbladder. So that can cause, obviously, stones in the bile duct. Is known as cholelithiasis, lithiasis meaning stone, and in the coli, the gallbladder. So you can have stones without infection, right? But obviously when the stone becomes infected, then of course it becomes a condition of cholecystitis or cholangitis. And that is just an infection of the bladder wall, which then of course, prompts the whole immunity and inflammation cascade with numerous proliferative bacteria flourishing. And actually, the gallbladder can be quite the source of of septic shock pretty quickly if you don't treat it quickly. And then there's all sorts of other associated conditions. Again, here's one that if you want to win at Scrabble, cholelithiasis is obstruction of gallbladder by gallstones in the biliary tract. So you can have stones actually in the gallbladder or actually further on down in the common bile duct. So cholelithiasis are gallstones that develop in the gallbladder when the bile becomes too concentrated or the liver excretes too much cholesterol. So what actually happens is these crystals fall out of the bile, and over time these crystals form stones. Trendy low-fat diets or fad diets can decrease bile transit time, so the bile has more time to be stagnant, and then the proliferation of these stones can be magnified with low-fat or trendy diets. So then the stones lodge in the common bile duct, which is colicky in nature. And just like your kidney stones, it's colicky because of the peristalsis trying to move the bile down, but now it's obstructed by the stone. And as I said, it can be high risk for a very severe infection. Usually can even be gram-negative. Risk factors include the 5 F's: female, fertile, fat, obese, 40, and fair. So that's a good common differential, the 5 F's. Clinical manifestations are right upper quadrant pain, obviously nausea and vomiting. Murphy sign, upon deep palpation, there's an inspiratory arrest and guarding at the site of the right upper quadrant area. Murphy's sign. Diagnostics, a good history, and endoscopy, and sometimes even removal of the stones using a Dormier basket with a procedure, an ERCP procedure. Labs will show a serum bili, indirect bili. Sorry. Yep. Okay. So what happened here? I'm sorry. I went forward. Okay. So yes. So you have an increase in serum bili, particularly your indirect. And if it's indirect, it means that the stone is lodged in the common bile duct. There may be some jaundice. There may be an increase in alkaline phosphatase, certainly an increase in WBC, most likely, and also an increase of the liver enzymes, ALT being most specific for the liver, and AST. Patients may present with jaundice, usually with many GI illnesses, occasionally with cholecystitis. Obviously, we know that it's the yellowing of the skin due to increased bile in the blood, and it first appears in the sclera. And too much production, it can be because of too much production of bile or an increase in hemolysis of RBCs. Bile salts back up into the blood and the tissues, which causes systemic or generalized itching, otherwise known as pruritus. Very common with patients with with liver failure, that they're pruritic and jaundiced. And it's important that you know that there are three types of hyperbilirubinemia, otherwise known as jaundice. There's the prehepatic, there's the hepatic, and the posthepatic. And the prehepatic is referred to as unconjugated or free bilirubin. Mixed, you can have free or not free bilirubin increases, or conjugate bilirubin as a result of post-hepatic bile obstruction. And I have another slide on that in the next picture. So with prehepatic jaundice, it's usually due to excessive destruction of red blood cells, hemolytic anemia, as with a transfusion reaction. Liver function is normal, but there's an increased bili. So something's happening before the liver, prehepatic jaundice. Intrahepatic jaundice, usually due to hepatitis or cirrhosis with bile backflow. Or posthepatic jaundice is usually due to obstruction of the bile flow, like with gallbladder disease. And here's just another slide. Have you look at this again. This will help you figure out whether or not it's conjugate or unconjugated hyperbilirubinemia. And I actually talked about this earlier, my first podcast. So just be aware of intrahepatic, extrahepatic, and prehepatic forms of jaundice. So the liver's role is to filter and detoxify toxins. It determines the metabolism, storage of fatty acids, monosaccharides, triglycerides, proteins, and cholesterol. Obviously, at times we need creation of new glucose, such as with an adrenaline rush associated with high outflow of the sympathetic nervous system. You need that gluconeogenesis. That's important for the liver. The liver also breaks down glucocorticoids such as cortisol, obviously produces bile, and can serve as a reservoir for blood and manufacture lymph. So when we have one of the first illnesses we'll talk about in terms of liver is hepatitis. There's obviously 5 types of hepatitis. We'll only talk about A, B, and C, but D and E also exist, but you won't probably be covering managing those patients. So with any viral illness, there's an incubation period, a prodrome period, acute stage, convalescence, and resolution phase. So with viral course of hepatitis, incubation means the point of exposure to the appearance of symptoms, even mild symptoms. Generally, that person, particularly with COVID, right, those people can be contagious, but they're not even aware that they have disease. Then once they have the onset of mild symptoms, enters into the prodromal phase, they feel like they're getting sick. Disregard that Gould comment there, sorry. So they have headache, fatigue, loss of appetite. And then they enter into the acute stage, which is the icteric phase, where they actually start to have the classic signs and symptoms with jaundice. And then the convalescent phase is post-icteric, jaundice goes away, the symptoms start to fade, and then you have the resolution stage. And as I said, there's 5 types of hepatitis. At the end of the day, hepatitis refers to inflammation of the liver. The liver cells are damaged in 2 ways. One, either by direct action of the virus or some sort of autoimmune response with cell-mediated responses. So viral hepatitis in itself, the liver is just inflamed, swollen, right up quadrant pain, jaundice with increases in bile, LFTs will rise. Hepatitis A is infectious, as we all probably know. It's transmitted by fecal to oral route, usually as a result of poor hand washing, poor handling of maybe diapers or contaminated shellfish. And so there you have your incubation period, 0.0 exposure. Then you have presentation of the symptoms with acute illness here. And it's important to note here's the early rise of IgM antibody, right? That's telling you, IgM is telling you that this is an acute infection. And then you have the convalescence period where the IgM starts to wane down, and now you have IgG rising, which means that this is now entered into the chronic phase, weeks after exposure, I should say. We all know about hepatitis B being healthcare practitioners, that it's transmitted by blood and body secretions, particularly sexually. Blood transfusions, obviously, and healthcare workers are high risk, IV drug users, and hemodialysis patients. So here again, you have the picture of the class of the virion itself, and then the here we have the map of exposure to acute and then the recovery phase. And again, you know, it's a long progressive illness, up to 25 weeks. So you have the IgM rise early, followed by the IgG later. And obviously, the virus produces two antigens, hepatitis B core antigen and hepatitis B E antigen. And infected cells, or the virions that are infected, produce hepatitis B surface antigen. That's the marker for active infection. Hopefully, you'll see it go away. Otherwise, a person might be at risk for chronic infection, or people who are carriers of hepatitis B will not have it go away. The HBsAg will remain. And hepatitis B coexists with HIV, and obviously there's a vaccine for it. Hepatitis C is the most common type, transmitted by blood transfusions, and it's chronic in nature. Symptoms tend to appear much later in life, and there's an increased risk of liver cancer. 20% of patients with hepatitis C may actually develop liver cancer. There's no vaccine for HCV, but there are drugs that can manage it. And the CDC is now recommending that all persons born from 1945 to 1965 be screened for hepatitis C virus. Now, obviously, if you get chronic liver disease, otherwise known as cirrhosis, the damaged liver cells are now scarred, fibrotic, and dying, necrotic. There's an increase in Kupffer cells, the macrophages, the specialized macrophages that live within the liver. There's chronic increases in PMNs and inflammatory cells that can clog bile. The liver itself becomes much nodular and smaller, as you can see in these pictures here, and bile backup is chronic in nature. Symptoms include fatigue, nausea, and anorexia with weight loss, pruritus, gynecomastia in males with impotence due to decreased production of sex hormones. They become anemic with loss of vitamin B12. You can't store iron in the liver. And most importantly, decreases in albumin, leads to a whole host of problems, but particularly leads to clotting disorders. So these patients are at risk for increased bleeding and thrombocytopenia. And hepatic encephalopathy usually ensues. Or can be prompted if they actually eat too much. Patients with liver disease, if they eat too much protein, it's that protein that breaks down to amino acids and ammonia, and they can't clear it, so the ammonia levels rise, and it causes mayhem on the brain, and the patients become hepatic, they become encephalopathic. One of the classic signs for this is if you ask them to hold their hands up like a cop, like a stop sign, like a cop, and then they start flapping. Their fingers just start flapping, which is a common sign of asterix. And then the decreased production of albumin. So they have decreased albumin in the blood, so that causes water to leak out of the vasculature, and it leaks out and forms ascites, which backs up in the blood, and then edema in the peripheral, in the lower limbs and such as well. Obviously, here's a picture of ascites. And then eventually you run into hepatorenal syndrome, the low systolic blood pressure due to the decreased albumin. The kidney doesn't receive the 25% of the cardiac output. The renal failure then ensues, which causes oliguria, hypotension, peripheral vasodilation, which only worsens the edema situation. And this is usually one of the reasons for this is alcoholic cirrhosis. And the treatment is to manage the fluid and electrolytes, the bleeding, infections, and encephalopathy, minimize the amount of protein the person is eating, administer systemic vasoconstrictors, and give transfusions of albumin, and obviously ultimately get them a new liver with transplantation. Also, when you have backup in the portal system, you have backup into the portal blood pressure increases in the portal circulation, which causes a backup in the venous system that feeds the heart, the inferior vena cava, and that there's these veins, that arteries and veins that provide nutrients and sustain the esophagus, and they're like varicosities in your legs, exactly the same thing. If you increase the pressure of fluid in your legs, then you have the outpouching of these small venules. And this is meant to be a low pressure system, so when you have backup in the portal system, backs up into this esophageal blood supply, and you end up with these arteries and veins that will start to pop. And it is one of the number one causes of death for patients with liver failure, because they pop and they bleed profusely, and it can be quite life-threatening. Here's just another picture of the circulation around the esophagus, and then these just all pop like your varicose veins in your legs, which unfortunately can be life-threatening. And we actually already talked about cirrhosis. Here's just another one of those lovely graphics that sort of shows many things, so I'm not going to talk about this one. And here we'll talk about the pancreas next. Don't forget, the pancreas it's referred to as an exocrine gland because it produces fluids. It produces amylase and lipase that is secreted into ducts, right? That's the function of an exocrine gland. So it empties contents into the duodenum and produces a large amount of water to dilute GI fluid before absorption. It secretes bicarbonate to neutralize hydrochloric acid. It secretes amylase for carbohydrate and protein metabolism. And lastly, secretes lipase for fat metabolism. You should be familiar with the common bile duct and this ampulla of Vata, where the two actually line up, the CBD and the pancreatic duct. Pancreatitis, very common with alcoholics and people with gallbladder disease. In acute pancreatitis, these digestive enzymes from the pancreas are prematurely activated, and they actually begin to digest the gland itself. Pancreatic autodigestion yields a profound inflammatory response. They can develop these huge pseudocysts in the back of their pancreas in the retroperitoneal space. They can hold up to a liter of fluid as a result of this inflammatory response. So you can just imagine how painful that must be. With continued autodigestion, more and more digestive enzymes are released, and it just becomes this incredibly vicious cycle. The clinical manifestations are left flank pain with severe nausea and vomiting, usually doubled over in pain. Labs for this would be an amylase. We talked about amylase is produced by every system in the body, but more specifically, you look for the elevation in lipase and an increased WBC. And I guess that's the end of this podcast. So I'll sorry, I didn't give myself a little. We'll move on to part 3, and that's the large colon. So thank you very much.